Morning, ladies and gentlemen, and welcome to the third day of the IFOMPT conference. So far, we've had a magnificent time. We've had some wonderful papers, a wide spectrum of science, education, and clinical practice. It's really come together, and I'm sure this morning will be just as good. Now, for those of you who are here today for the first time, I need to just say, please, can you use your apps and post your questions for the session? They'll come up and we'll take them from the stage here. And please also rate. There's an evaluation button, and please don't forget to do that for this session. Now, it's my great pleasure to introduce Dr. Annina Schmid, who some of us have heard already, but for those of you who haven't, she is a Swiss physiotherapist who qualified in Switzerland and then went to Curtin University in Perth and did her master's in manipulative physiotherapy, went back to Switzerland and worked clinically and in research, and then went to Queensland, to Brisbane, to do her PhD. She's got a great interest in neuropathology and neural entrapment, and she will be speaking to us today on expanding our understanding of entrapment neuropathies and neural pathology. I also want to tell you that she's just been made associate professor at Oxford University, Nuffield. So we're very honored to have you here, so please come and speak to us.
Thank you very much for the kind introduction. Now let's try and shake the physio world a bit today if we can. I was asked to talk about expanding our understanding of entrapment neuropathies and neural pathology to you today. And as you're all familiar with, entrapment neuropathies are caused by pressure on peripheral nerves as they travel through narrow anatomical spaces. And common entrapment neuropathies are certainly carpal tunnel syndrome, cubital tunnel syndrome, and cervical or lumbar radiculopathies. But there are also a bit more controversial entrapment neuropathies, such as Morton's neuroma, piriformis syndrome, or tarsal tunnel syndrome. Now, when I went to school, it was pretty clear that it is quite simple to diagnose patients with entrapment neuropathies. And indeed, if you follow the diagnostic guidelines today for both, for example, carpal tunnel syndrome and radiculopathies, the guidelines say that patients should have a dermatomal or a territorial pattern of symptoms. They should have positive electrodiagnostic tests if these are available, meaning that the nerve conduction velocity is slowed. And when we do a bedside neurological examination, it should be positive, meaning that patients have difficulties feeling light touch, muscle strength, and reflexes, which is the standard bedside neurological examination. Now, in physiotherapy, and that is not in the guidelines, we also use neurodynamic tests to diagnose or to see whether a nerve involvement is more likely. Now, today I would like to discuss with you 3 buts. First, what if a patient has clear symptoms, for example, of a carpal tunnel syndrome, he has tingling, he shakes his hand, and it gets better. But when I do the neurological bedside tests, like light touch, muscle strength, it is completely normal. Does that then mean he doesn't have an entrapment neuropathy? The second but, what if a neurodynamic test is negative in a patient where I believe he has an entrapment neuropathy? Does that then exclude such a problem? Most importantly, what happens if patients have symptoms that do not follow the anatomical, dermatomal, or territorial pattern? But what if they have widespread symptoms? Does that then mean they don't have an entrapment neuropathy? And today I would like to discuss these with you, and I will also have a slight excursion into the double crush syndrome, which has been very topical. And I would like to discuss consequences for diagnosis and management with you today. Now first, what if neurological examination is normal in patients with entrapment neuropathy? And for that I refer to light touch, reflexes, muscle strength, which we commonly do. And if you have access to neurophysiology, that would also count to a neurological examination. Now, in order to answer this question, I would like to take you back to the actual anatomy of a nerve trunk. And this is an electron microscopy image that I took of a sciatic nerve of a rat. And you can see that we have a lot of different nerve fibers within the peripheral nerve trunk. We have the thick myelinated big axons, and then we have small unmyelinated axons, for example, C fibers, which are responsible for warm sensations or nociceptions. And we have the thin myelinated nerve fibers, which mediate cold and nociception. Now, when we do our standard bedside neurological examination, we exclusively test this thick myelinated fiber population. Even the standard electrodiagnostic tests do not test anything else than the thick myelinated fiber. Now, of note, the thick myelinated fiber only make up 20% of a nerve trunk. So that basically means that we might be neglecting 80% of a nerve trunk when relying on these tests. Now, how does it come that we are relying purely on these large fiber tests in clinics? And I believe that comes historically, because in animal models that have been used to mimic nerve-related problems, what they have done is that they ligate a nerve or chronically constrict a nerve quite heavily, which is an acute and a rather severe injury. Now, if they do that, the large fiber are indeed the first ones to degenerate. However, our patients certainly do not have an acute injury most of the time, and they also do not have a very severe nerve compression, but usually a rather mild one. And it therefore remains unknown whether what animal models so far have shown actually applies to patients with entrapment neuropathy. Now, in order to address this problem, we refined an animal model that mimics mild nerve compression. And we did that by me operating a silicone tube around the sciatic nerve of rats. Now, these rats are young at the time of the tube placement, meaning that the tube itself does not constrict the nerve, but it is just snugly sitting around that nerve. Now, the animals then are kept happy over 3 months, and they feed nicely so that they start growing. And as they grow, the nerve starts to slowly compress within that tube. So we have a model of a chronically developing, very mild entrapment neuropathy, which mimics what we see in our patients. And I would like to show you what we find in this model, what happens pathophysiologically. Now, first of all, let's look at the demyelination of those larger fibers or the myelinated fibers. This is a longitudinal section through a sciatic nerve. The rat on the left side is a normal nerve that has not been compressed. And the green stain is the myelin, stained with myelin basic protein. And you can see a really nice myelin sheath. On the right side is the nerve that has been compressed over 3 months very lightly. And you can see that there is almost complete demyelination. So it's quite a significant demyelination, really. And when we quantify that, this is statistically significant, and it is dose-dependent. So the tighter the tube is, so the more the compression, the more demyelination. And the less we compress, the less demyelination. Now, if we look at this demyelination, we thought, well, the large fibers most certainly must degenerate because you have such an amazing amount of demyelination. However, when we looked at it histologically, that is what we found. In fact, when you look at it, we did not find anything at all, because the fibers on the left side, here stained with protein gene product, staining all the fibers within a nerve, they had exactly visually the same amount of fibers at the compressed site. So that was a bit puzzling, and that really was contradicting to what other previous models have seen. So we wanted to look a bit more closely. And what we did is that we stained specifically for the small fiber population with calcitonin gene-related peptide. And what we identified were these varicose, dotted-looking fibers. And these varicose fibers are an indication of a degeneration. Now, it was even more puzzling because that is really not what we thought would happen in a compression, that the small fibers start to degenerate. So we looked at the level of the dorsal root ganglia to kind of see whether we made a mistake. And when we looked there, we stained with activating transcription factor 3, which is upregulated if an axon is damaged. And you can see that the upregulation of this factor was predominantly in the small fiber population, further supporting that there's indeed something happening to these small fibers in an entrapment neuropathy. Now, when we quantified that, we also confirmed that it was this small fiber population that was lost at the level of the dorsal root ganglion. Now, that poses the question whether we are indeed neglecting the small fibers in our patients. I would like to point out, though, that this was an animal model, and obviously it's difficult to say whether that translates to what we see in our patients. So what we did is we actually did that study, and we used carpal tunnel syndrome as a model system to look at it. Now, obviously, I can't cut out the median nerve in these patients, but what I can do is I can take a skin biopsy in the median nerve territory. And as you all know, a substantial proportion of our sensory fibers start and end in the skin. So therefore, the skin biopsy is a great window that allows me to look into the nervous system. And when we did that, we first looked at the large axons. So I quantified the number of Meissner corpuscles. Meissner corpuscles are the receptors of the large myelinated A-beta fibers, so the touch receptors. And as you can see, we did not find a significant loss of these large fiber receptors. Similarly, when we quantified the number of myelinated dermal fibers, we could not find a significant loss of the myelinated fiber population in patients with carpal tunnel syndrome, further suggesting that the large axons remain spared. However, when we looked at the small fibers, it was a really different story. And I would like to show you here, this is a skin biopsy with the dermal layer at the bottom and the epidermal layer on the top. And we know that those fibers in red that penetrate into the epidermal layer are exclusively small fibers, because the large fibers never penetrate into the epidermal layer. So we can basically count how many nerve fibers does a patient have in the epidermal layer of the skin, and that gives us an idea about potential small fiber degeneration. Now, we did that, and that is an age and gender matched patient with a carpal tunnel syndrome, and you can already see visually that he has a significant fallout of the small fiber population in the skin. And when we quantify that, that was significantly a significant downregulation of that small fiber population in the skin. And I would like to highlight that this was completely independent of the electrodiagnostic test result. For example, there was one patient with a very mild electrodiagnostic carpal tunnel syndrome, but he had almost no small fibers left in his skin. And that is not surprising, because electrodiagnostic tests purely test the large fibers and do not say anything at all about what happens to the small fiber population. Now, obviously, the question is a bit, if patients have this small fiber degeneration, what happens to them? Can they actually regenerate, for example, if they have surgery? And that is what we are currently looking at, and I would like to show you some preliminary data, which is quite intriguing, I think. So if we have patients with carpal tunnel syndrome and they get operated 3 months when they come back, there is not an awful lot of regeneration as yet. However, at 6 months, there is at least partial reinnervation of the small fibers into the skin. Interestingly, though, if patients have no surgery, they continue to show a loss of these small fiber population over time. And even though we don't know exactly as yet whether that is the truth, but that makes me think, even if it's a simple carpal tunnel syndrome, maybe we have to start thinking, how long do we really want to leave those patients before they get treatment? Now, at the 6 months time point, I would like to show you single patients, pre and post-surgery. And what I would like to point out is that there is a significant variation in the regeneration capacity of our patients. In orange are those patients that even that they had surgery, they continue to degenerate in their small fibers. And we are currently looking whether that might explain why some patients with a lower regeneration capacity do not benefit from surgery. Most importantly, we're currently looking at the genetic profile in the skin, the expression profiles in the skin, to see whether we can find a molecular signature that might facilitate or prohibit regeneration. Now, for you, what might be of interest is that we also had some patients with completely normal electrodiagnostics in our patient cohort, and these are the ones. And as you can see, a significant proportion of these patients actually had an actual structural loss of their small fibers. So that makes me really think that it is insufficient to solely rely on tests for the large fiber integrity. How can we test that, though, in clinics? And I'm not advocating that you're taking skin biopsies, obviously, but there are other tests that we can do in clinics. And quantitative sensory testing is something that has become quite fashionable over the past decade, and quite commonly it is used in a neurological setting. And we actually confirmed that quantitative sensory testing is able to pick up this loss of small fiber function. As you can see here, patients with carpal tunnel syndrome have significantly more difficulties feeling cold and warm stimuli, which are mediated by A delta and C fibers respectively. Now, again, you might not have access to these kind of thermal stimulators in your clinic. So the question is, can you use a very simple tool to test the small fiber population? And some of you might have seen the Rapid 5 presentation by Colette Reithalsch, where we looked at the sensitivity and the specificity of such very simple tests for cold thresholds and pinprick thresholds for A delta fibers to look at whether we can pick up such an actual loss, a structural degeneration of those fibers compared to the gold standard of the skin biopsy. And as you can see, the sensitivity is rather shocking, I would say. However, the specificity is really good, meaning that if a patient has indeed a problem feeling cold or feeling pinprick as sharp, it makes it highly likely that he has an actual structural loss of the small fibers. If you have a negative test, though, you can't say that this patient doesn't have a small fiber degeneration. Now, there's a lot more work needed, and we are currently looking at a multi-center study together with Brigitte Zampin in Australia, Karina Böttger in Switzerland, and in Oxford at these tests in relation to the standardized quantitative sensory testing. And I hope we can tell you more about these tests in a couple of years, because it's really important that as clinicians, we have simple bedside tests to test these small fibers, because we just simply can't afford to neglect 80% of the fiber population in a peripheral nerve. Now, what about those patients now with negative neurodynamic tests? Now, we know that up to 58% of patients with lumbar radiculopathy have a completely normal straight leg raise. And also, it has been reported that up to 72% of patients with carpal tunnel syndrome have completely normal upper limb neurodynamic tests. So the question arises why that is, because commonly as physiotherapists, we interpret a neurodynamic test as a suggestion of nerve involvement. And these patients had a clear diagnosis of nerve involvement, for example, with electrodiagnostic tests. Now, in order to kind of find out what is going on, we did the following study. We took patients with carpal tunnel syndrome. They were subgrouped into those with positive and those with negative upper limb neurodynamic tests. And we also had a healthy control group. And what we did is we used standardized quantitative sensory testing, evaluating the large as well as the small fiber population with different thermal and mechanical stimuli. And we were wondering whether there's a difference in nerve fiber function of these different fibers in those two subgroups of patients. And this is what we found for detection thresholds. As you can see here, in orange and in red are the patients with negative and positive neurodynamic tests. And you can see that they had significant difficulties feeling cold and warm, so again proved the small fiber problem. They also had problems feeling light touch. Interestingly, though, I would like to highlight warm detection. And that is the only parameter that differentiated those patients with negative neurodynamic tests from those with positive neurodynamic tests. But have a look which direction it actually goes. Counterintuitively, it is actually those patients with a negative neurodynamic test that have more difficulties feeling the warm sensation. So that means that patients with negative neurodynamic tests in our study had a more severe dysfunction of their small fiber population. And that is really quite puzzling. And at the moment, it remains speculative, but we believe that this is true simply because we are not the only ones that report that. There's an elegant study by Boyd, has been published in patients with diabetic polyneuropathies, and he finds a very similar pattern. The patients with severe diabetic polyneuropathy are less neurally mechanosensitive. Now, a potential explanation, as I said, this is purely speculative at the moment, could be the nerve in a worm. We commonly accept that mechanosensitivity is in part mediated by this nerve in a worm, and they are, to a vast majority, small fibers. So if it is indeed that these small fibers degenerate in our patients with entrapment neuropathies, it might well be that these patients become less mechanosensitive if they have a more significant degeneration of these small fibers. What does it mean for clinics? For clinics, it means that we should never interpret the neurodynamic tests in isolation, because it is not a test that has a good enough clinometric property to detect, for example, carpal tunnel syndrome or cervical radiculopathy. But we should always interpret it in the context of the neurological examination. And specifically, again, it seems that it is important that we test the small fiber population to interpret these tests properly. Now, let's come to one topic that is really quite close to my heart, and that is, what if patients have extraterritorial symptoms? And we all have learned that a patient with carpal tunnel syndrome should have symptoms in the median nerve territory of the hand, and in an L5 radiculopathy, they should have symptoms that go exactly in the dermatome. And then I went to clinics, and it was just not like that. And I'm sure you have all made the same experiences. Nowadays, we know that up to 70% of patients with carpal tunnel syndrome have, for example, symptoms affecting the whole hand. And in patients with lumbar and cervical radiculopathy, it's actually 2/3. So that means the majority of patients do not have a dermatomal pattern. So what might cause this spread of symptoms? And I would like to go back to the animal model to explain that, where we found that even a very mild nerve compression was sufficient to induce a neuroinflammatory reaction, potentially because there was some demyelination, there were neutrophils attracted to the lesion site. These neutrophils attract other immune cells, such as macrophages. Macrophages are phagocytic cells, so that means they gobble up the myelin and clear the debris. And when they do that, they start to release certain inflammatory mediators, which we call cytokines. Cytokines are very important because they attract other immune cells. For example, they attract T lymphocytes. And T lymphocytes also secrete cytokines, which will now contribute to even a more inflammatory environment within that nerve trunk. Now, if axons, myelinated axons, lie in such an inflammatory environment, what happens is that the Schwann cells become really unhappy. And Schwann cells normally produce myelin, but they also have a really important immune-competent function, meaning that if they are strongly activated in an inflammatory environment, they start to release quite nasty inflammatory mediators, as you can see here. And that will further contribute to a quite significant inflammatory reaction of that nerve. Now, from animal models, we know that an intraneural inflammatory action will lower the firing threshold of axons, meaning that they fire much more strongly and faster. Now, if that happens in a nociceptive fiber, that might well mean that many more action potential might reach the brain, where it might be interpreted as a painful experience. So neuroinflammation has been very closely linked to neuropathic pain behavior, both in humans, but also in rats. Now, such a local immune inflammation might well explain localized dermatomal symptoms, but it still cannot explain remote symptoms. So we started to look further away, and specifically, we looked at the level of the dorsal root ganglion. Now, the level of the dorsal root ganglia, as I said, contains the sensory cell bodies, and I would like to show you here a video that my colleague Steve West took. He's a postdoc in our lab, and he has done a fantastic, very difficult technique so that he can image a whole dorsal root ganglia. And I would like to have you to focus on the green cells. And you can see that this is it's just a cross-section through a dorsal root ganglion. You can see that there are thousands and thousands and thousands of neurons within a single dorsal root ganglia. So it's really quite snugly inside a dorsal root ganglion. Now keep that in mind as we now continue the story. Now we looked at the level of the dorsal root ganglia, what happens in regards to inflammation. First of all, I would like to show you what we found for satellite glial cells. Satellite glial cells is nothing else than Schwann cells in the dorsal root ganglia. And you can see that on the side where animals received a very mild nerve compression, very far away from where we are looking now in the dorsal root ganglia, you can see that the satellite glial cells started to proliferate. This is a sign of activation of these immune-competent cells. We did, however, also find an increased recruitment of macrophages into the dorsal root ganglia, far away from where the injury site is. Similarly, T lymphocytes were strongly attracted into the dorsal root ganglia, again, very far away from the actual compression site. Now, how can such an immune-inflammatory reaction at remote site explain spread of symptoms? Let's do a bit of anatomy. If you have a patient with a tarsal tunnel syndrome, which affects the tibial nerve in the ankle, he gets a local inflammatory reaction, and he will definitely get symptoms in the tibial nerve territory. However, it might well be that he also gets an inflammatory reaction at the level of the dorsal root ganglion, meaning that all these neurons that I showed you before in the video from Steve might start lowering their firing threshold because they lie in an inflammatory environment. Now, the tibial nerve goes into L5. What else goes into L5? It is certainly the peroneal nerve. So if the peroneal neurons now at the level of the dorsal root ganglion lie in an inflammatory environment and start lowering their firing threshold, the patient might well start experiencing symptoms in the innervation territory of the peroneal nerve. And we can continue this story because the sural nerve also goes into L5. And if it starts lowering the firing threshold, the patient will feel symptoms now in a sural nerve territory, even though the sural nerve has absolutely not been compressed in the periphery. And of course, the sciatic nerve goes also through L5, so patients all of a sudden with a simple tarsal tunnel syndrome might start to experience symptoms that radiate up the leg. So a remote immune inflammation might therefore well explain spread of symptoms. And in clinics, that means that if patients have spread of symptoms, that does not mean that they do not have an entrapment neuropathy. It might well mean that they have some remote mechanisms at play. Now, what about this? And this is something that has been very topical in physiotherapy. And the phenomenon is that it has been described by Upton and McComas in the 70s that if patients have a carpal tunnel syndrome, they are more likely to also develop a cervical radiculopathy. And it has been termed the double crush hypothesis. Now, it has been quite controversial, but actually when you summarize the literature, it is rather consistent. So this is the prevalence of radiculopathy in the general population, which is described around 1% or even less than 1%. And if patients have a carpal tunnel syndrome, the prevalence of a cervical radiculopathy is consistently higher in all the studies. Of course, there's a lot of variation, and that probably depends on the kind of diagnostic criterion that they use to diagnose both carpal tunnel syndrome and radiculopathy. But it is definitely consistently higher, so there seems to be clinically something to this double crush syndrome. And so far, the pathomechanisms that have been used to explain this syndrome is axonal transport, meaning that if axonal transport becomes impaired at one side, it might well affect the nerve distally and make it more prone to a second injury. And that might well explain why a patient has radiculopathy and carpal tunnel syndrome in the same neural pathway. But in fact doesn't explain why we also see patients that have an ulnar neuropathy and a carpal tunnel syndrome which have completely different axonal transport systems. So we hypothesized that it might be something else that might be contributing to this double cross syndrome. And we were thinking about immune cell memory. Now, I explain you what we think might happen. If you have an injury, as I showed you before, you might activate immune cells such as macrophages and T cells. If they become activated, especially the T cells, they can form a memory. So there's a subset of these T cells are memory T cells. And we believe it could be, or we not believe, we hypothesize it could be that if T cells, for example, recognize a myelin debris, they will start forming a memory of that myelin debris. And if a patient now has a second injury, which might be very mild, but there is a bit of myelin debris there, it might activate those T cells in an exacerbated fashion. And an exacerbated T cell reaction means an exacerbated inflammation, probably means exacerbated symptoms as well. Now, you're all familiar with this concept of immune memory from an allergic reaction, just that an allergic reaction is an immune memory to a foreign antigen, whereas here we are talking more about autoimmune mechanisms, because the myelin itself is a body-own protein. Now, I would like to show some of the work that our student Henry Munyanduki has been doing back in Brisbane, where he now looked exactly at that paradigm in an animal model. So if he puts a tube only around the sciatic nerve, there is a slight increase of T cell reaction. If he puts a slight tube around the tibial nerve, there is probably a bit, but not much at all. But if the rats receive first a sciatic tube, then a tibial tube, so a double crush basically, there is an exacerbated reaction and activation of these T cells, which seems to support the hypothesis that we have that these T cells have somehow been conditioned and have formed a memory. We did, however, not only find that in the periphery, but also at the level of the dorsal root ganglia. And here again, the satellite glial cells, which are Schwann cells but have an important immune competent function. And you can see that in the condition where the animals received this double crush, there was a significant exacerbation of the satellite glial cell activation. So this is something to keep in mind, and there's still a lot more research needed in this area, but we believe there might be something about the immune system that might contribute to something what we see with this double crush syndrome. But what does that now mean for the management of our patients with entrapment neuropathy? It's probably like head scratch, oh my God, how can I actually control that immune system? Maybe just give them medication. And most importantly, what we have probably all, what has been quite fashionable, is basically hands off. Yeah? If patients have spread of symptoms, hands off, do not treat them with your hands. You know, use more centrally directed treatments. And I believe that is very important. But today, I would like to make a pledge for the periphery, for a very simple reason. I have shown you that the majority of patients with entrapment neuropathies have widespread symptoms. But still, if we give them a cortisone injection, or if they are being operated, they have an immediate relief of their symptoms. So that means the peripheral trigger is incredibly important, and if we can remove the peripheral trigger, the widespread symptoms resolve in these patients. You can talk to Brigitte Tampin. She sees a lot of patients with cervical radiculopathy, and I see a lot of patients with carpal tunnel syndrome as well. The next day, they don't have symptoms anymore if they get operated. So it is really quite important to probably not forget that peripheral trigger. The question is, with our physiotherapeutic methods, what can we actually do to promote, like with our techniques in regards to that inflammatory action? And I would like to show you a study that we have done in patients with carpal tunnel syndrome again, where we looked whether we can reduce intraneural edema. Now, in carpal tunnel syndrome, on T2 weighted images, we know that the median nerve has an elevated signal intensity. And on T2, an elevated signal intensity means an increased water content, which is reflective of edema. And edema most likely is due to inflammation. So we were wondering whether simple nerve and tendon gliding exercises can reduce that signal intensity of the median nerve locally. And we did the following methods. So we had patients with mild to moderate carpal tunnel syndrome. They did a structural T2 weighted scan, and then were randomly allocated to either nerve and tendon gliding exercises or wearing a splint. Now, after 10 minutes of either wearing the splint or nerve and tendon gliding exercises, we repeated the MRI again to see whether there were immediate effects on the intraneural edema. They then went home and either did wear the splint at night, because we know there is evidence that wearing a splint at night is beneficial for these patients, or they were doing nerve and tendon gliding exercises in quite a high dose. So we asked them to do the set of exercise every hour up to 8 times. With the idea, if you want to have edema evacuation, you have to do it very, very regularly. And after 1 week, we repeated the MRI again to see what happened to the nerve. We also had a control group of patients who had an MRI 1 week apart, simply to see that there is not much natural fluctuation of the signal intensity within that nerve. And this is the results that I would like to show you. This has been published. If you want to read in more detail, it's all available. This is the level of the radio-ulnar joint, and it's the signal intensity of the median nerve. And you can see that there was no immediate effect after 10 minutes of exercises or splinting. However, after 1 week of both exercising and splinting, there was a significant reduction of the intraneural signal intensity of the median nerve. And because there was no change in the no-intervention group, we believe that this is reflective of those exercises and the splinting being able to reduce intraneural inflammation, or which is a clinical correlate for the signal intensity that we are measuring. Now, obviously, the nicest thing would again be to look at the nerve and actually look at the immune cells themselves. So can't do it in patients. But Marúcia Shakur is a colleague of mine in Brazil. She's a biologist, and she has rats. So what she does is that she operated those rats with quite a severe injury. I would like to point out it is a chronic constriction injury, quite an acute injury. Nevertheless, she did either no treatment for these rats right after injury, or these rats underwent 2 weeks of neurodynamic exercises, 10 minutes every second day. And she's a biologist, but she did exactly what we probably would do, is a tensioner exercise, straight leg raised position, passive mobilization of the ankle. And after 8 or so minutes, she went into a slump position and continued to do a tensioner over the foot. So really makes us proud as a physiotherapist, isn't it? So what she found is the following. At the level of the dorsal root ganglia, that is the part that I would like to show you. We're talking about these satellite glial cells again. In naive animals, you can see there's almost no activation of these satellite glial cells. In animals that received a nerve injury, you can see a significant activation of these satellite glial cells. And in those animals that were treated, there's a significant reduction of this proliferation of the satellite glial cells. And as you can see here, she confirmed that as well with Western blots, meaning that she quantified the proteins of the satellite glial cells in the dorsal root ganglia, and that was a significant reduction with the exercises or with the passive tensioner mobilization in those animals that received a rather severe nerve injury. So that suggests that our methods are probably quite potent, not only locally, but also at remote sites. And we should not underestimate what we can potentially achieve, even with a peripheral treatment, even at remote sites. Now, therefore, and especially the ones that have been at the KLE yesterday, you know that to move and to use your body, it doesn't just only need the brain. You certainly need your legs, and I can feel them a bit after yesterday evening. So we should not forget the periphery, but we should try and integrate it into our reasoning and management together with all the different changes at the central level. Because in the end, a patient does not only exist of periphery or brain, but is the complex interplay between the two. Now, in summary, I would suggest that we start including tests for the small fiber function in patients, in our patients when we do a neurological examination. And that would be something like a pinprick, for example, because I think we cannot afford to just neglect 80% of the nerve fibers. We also should think about interpreting neurodynamic tests in the context of a thorough neurological assessment, because it might well be that those patients who have normal neurodynamic tests have, in fact, a more severe nerve dysfunction. A non-anatomical distribution of positive signs or symptoms does not exclude an entrapment neuropathy, but it might well point towards remote mechanisms such as changes at the level of the dorsal root ganglia, and most certainly, which I haven't been talking about, at the level of the spinal cord or cortical areas. And last but not least, an important message, let's not forget the periphery, but let's stick to the biopsychosocial and actually try and integrate everything into one. Thank you very much, and I'd like to especially thank all the people that have been involved with this study.
Thank you very much for an absolutely fascinating talk. If you want to stay where you are, unfortunately, I've not been able to get any questions up here, so maybe I could have some technical help. We'll take some questions in a minute. One of the nice things is that what you bring us back to with your research is that really detailed clinical examination and extensive clinical examination is really of the essence, because even if we don't have the equipment that you do and the testing facilities in our own clinics, what we do have is the skill to really examine carefully and then take it from there.
I completely agree, and I believe, it's a topical area, these small fibers, and obviously entrapment neuropathies are not the only patients where we start seeing the small fiber population coming up quite importantly. But certainly, I believe we have an important role to play as physiotherapists, because very often you see a GP that sends you a patient says, yeah, he doesn't have carpal tunnel syndrome because the electrodiagnostic tests were normal. But really, if we only test 20% of the fibers, can really make that statement. So I believe we are in a really great position to try and integrate the rest of the 80% of the fibers in our clinical examination. Absolutely.
Okay, so I've got some questions for you. For those diagnosed to have entrapment neuropathy, will neurotissue mobilization techniques, both active or passive, cause further damage to the neural tissue mechanically? Any guidelines for the application of nerve mobilization with carpal tunnel?
Yeah, so that is a really good question, and that is quite often a bit the fear that we have, isn't it? In the literature, it doesn't suggest that we are actually causing damage. Of course, that probably depends on how you dose these treatments. But there's a nice study from Bob Nee where he showed that there were no detrimental effects in patients with radiating arm pain when he did this kind of neurodynamic treatment approaches. And Colette Reitholt has also published a study in spinally referred leg pain and radiculopathy. And even in patients with radiculopathy, in fact, there was no detrimental effects. The large fiber function even seemed to show a bit of trend towards improvement. So I believe at the right dose, these treatments might well not have a detrimental effect, but it probably really depends on what you do, and there's a lot more research needed to look at the management, because at the moment, the literature on how these exercises work and the mechanisms of action is really promising. But when we translate it to randomized controlled trials with all the problems of these trials, we usually find that it is a bit more controversial whether it actually works or not. But that might simply have to do that it might not be targeted to the specific patient individually. Okay.
Thank you very much, Dr. Schmid. We've really enjoyed having you here, and I hope you've enjoyed being here as much as we have to have you. So thank you very much, and please say thank you.